very simple and a very clinical OSCE. So this is your first. So we all today have become very accustomed to using the pulse oximeter in the delivery room. What is the target SpO2 at birth as per the NRP 2020? What is the basis of this target SpO2 and what is the target SpO2 that we use? We increasingly manage a lot of ELBW babies, a lot of sick babies inside NICUs, especially the inborn units, and even those that are only subserving the outborn babies. There is a concept of what we know as the golden hour. So just list the 5 components of the golden hour management of ELBW newborns. You could put them in any order. Some of these are already shown in this photograph, which are critical in ensuring good short-term as well as long-term outcomes of these fragile babies. A very basic question. As per the latest National Family Health Survey 5, which was released recently, what is the current neonatal mortality rate and the infant mortality rate? And what are the 3 leading causes of NMR in our country? ROP screening is a very integral part of the care that we provide. What are the screening criteria for ROP as per the Rashtriya Bal Swasthya Karyakram? We all have AAP guidelines. We have individual unit protocols. We may have some variation, but what are the guidelines as per the Government of India RBSK program across the country? What gestation, what weight? When should it be done? What are the eye drops used for dilating the eyes in ROP? What is their concentration? How frequently should they be administered? So define the type 1 and type 2 ROP. Earlier, we had terms like pre-threshold, threshold. Today, based on accumulating evidence, our decision to treat is based on this classification of either extent, the severity, the location, and we have terminologies which go by type 1 and type 2. So define type 1, define type 2 ROP. I'll quickly play this video. So what is the Silverman-Anderson score of this late preterm around 2.4 kg baby that we recently had? This is a standard scoring system. We teach our residents, we teach our nursing staff, and we use it to serially monitor the severity of the respiratory distress. And what is the algorithm? Quickly, can you draw out an algorithm for the management of distress in this late preterm 2.4 kg male baby? What would be your first therapy now? When do you consider surfactant in this baby? As per the standard protocol or the recent European guidelines of 2022, or whatever is your unit protocol, when do you consider surfactant? quickly draw out an algorithm. Okay, this is again a video grab of what is the current technique most of us practice for administering surfactant to babies that require it. Yeah, so some of the precautions have already been highlighted. So quickly list out what are the benefits of this technique. Name the technique. What are the benefits of this technique in terms of short-term and long-term benefits? We all are very familiar with the use of antenatal corticosteroids, though usage across our country leaves a lot of scope for improvement. What is the dose? What is the route of administration as recommended by the Ministry of Health, Government of India? What is the gestational age of the mother between what periods? What is the agent that is recommended? And what is the dosing schedule? And what are the benefits in terms of percentage decrease in the immediate outcomes of the baby? It is shown here because this forms the basis for the Cochrane logo, or the Cochrane symbol, these benefits. So quickly, ma'am, can I show the answers as well?
Yes, I think so. They have all answered in the Q&A box.
Okay.
But now when you show the answers, they can check themselves. So
yeah. So just give me a second, please.
Yeah.
Is my screen visible?
Yes.
Yeah. So the first question was, what is the target SpO2 at birth as per the latest NRP 2020 guidelines, and what is the basis for this target SpO2? So as we all know, over the last 2 NRP editions, we have started using the target SpO2 as flashed on this slide. We understand that the normal healthy term babies also take about 10 minutes to reach a preductal saturation of between 85 to 95%. All of us must continue to use a preductal SpO2 probe, ideally as per the NRP with a signal extraction technology. There are various ways of doing this, either applying the probe first and then connecting to the monitor, or vice versa. I think NRP says connect it onto the baby and then connect it to the monitor. And these numbers have come from a study way back in 2010 by Dawson et al., which are based on the, I think, median of the interquartile ranges. They studied a large number of babies who were delivered in an era of, where DCC was not normal or not the standard of care, but they found that it took at least 10 minutes after birth for most babies to achieve. And we need to target these as the saturations. And we also must remember that in babies who are born term beyond 37 weeks of gestation, we must begin with an initial FiO2 of only room air, 21%. Babies who are below 28 weeks, we begin with an FiO2 of around 30%. So this requires the need of a blender. Most settings that we work in may not have the air compressor on the wall. So we need to at least try and build our system so that we're able to use this blender, because it's been shown that even a short exposure to half an hour, 1 hour, or even shorter can have long-term consequences because of oxygen free radical injury. Between 28 to 31 weeks, there is a little bit of a gray zone, but we must understand that we should start maybe around 30% and then titrate based on these target saturations. Now, the second question, the 5 components of the golden hour management, they actually are a continuum from the antenatal period through the delivery period and later on. 5 things which we as pediatricians can ensure is delayed cord clamping. We know all the benefits of delayed cord clamping in preterm babies, and as per the NRP, any preterm baby, in fact, term babies as well. So the benefits in preterm babies are it stabilizes the blood pressure, decreases the need of inotropes, fluid boluses, and helps thus prevent the risk of intraventricular hemorrhage. The second is a bundle care to ensure thermoregulation. It includes a combination of keeping the delivery room warm, ensuring your warmer is on before delivery. Below 32 weeks, the use of clean food grade plastic wraps or cling wraps. This could be ready-made. This could be fashioned from whatever is available. Also, the use of exothermic mattresses. And in babies who are beyond the 32-34 mark, where they are stable, skin-to-skin care. So this bundle care is important. Early delivery of delivery room CPAP using an appropriate interface. Again, preferably with a blended air oxygen mixture with a PEEP of maybe around 5 and FiO2 as required and titrated to match the target SpO2. Early use, selective use of surfactant by either the Lisa technique or the MIST technique in babies who need the surfactant. Early feeding in almost all babies, TPN in a select subgroup where you can't begin early enteral feeding. And there could be others which could form the golden hour care, but this kind of is key, and attention to detail and meticulous care during these procedures is critical to ensuring good outcomes, both immediate as well as long term. This is an easy one, but we can see that we have made some progress. The infant mortality rate is today 28.3 per 1,000 live births, and the NMR is almost more than 3/4 of this, 21.7. The causes, preterm birth complications remain the big chunk. Infections is the next, and birth asphyxia is the next. That's why the INAP focuses on some goals to reduce mortality due to these 3 leading causes. India is a land of striking contrasts, and we have regions in our country, or even within the same state, same region of a city, with varying mortality, and we need to pay attention to our basic processes. What are the screening criteria for ROP as per the RBSK program and the eye drops for installation? Well, we have guidelines which have identified less than 2 kg, a gestation less than 34 weeks, against AAP, in contrast, which says less than 1,500, less than 32 weeks. This is because of the variability in the care that we seem to be providing across the length and breadth of our country. And even in babies beyond 34 to 36 weeks who have risk factors and an unstable clinical course. The drops we use is a combination of phenylephrine 5% with tropicamide 0.8, which is diluted 1:1, instilled 2 to 3 times 1 hour before the procedure. Mandatory for all of us to ensure screening at 28 days postnatal age. In the extreme low birth weight, extreme preterm population, we need to do it early, maybe around 3 weeks to pick up the aggressive posterior ROP. But 4 weeks is the number that we all can remember. We must ensure ROP good screening. What is type 1, type 2 ROP? As flashed, type 1 is any stage in zone 1 with plus disease, or a stage 3 in zone without plus, or stage 2 or 3 in zone 2 with plus. And these zones are as shown on this slide. Type 2 is in the zone 1, stage 1 or 2 without plus, or in zone 2, stage 3 without plus. We need to have access to an ophthalmologist with expertise in screening, with ability to do laser where required, or the therapy with bevacizumab where required. And unless we do this before discharge, we are liable to problems in the follow-up. This is a Silverman score calculation in a baby. Here we saw the baby had audible grunt, visible severe retractions both in the lower chest and in the xiphoid, had nasal flare. So the score is easily anything from 8 to 9. This is a language that all of us need to teach our residents, teach our sisters, so that we are able to serially monitor and follow up these babies. Now, this is one example of a protocol from AIMS. Units can modify this based on their unit protocols. A baby beyond 28 weeks with distress at birth receives early CPAP. And then in the NICU with CPAP pressures which range from 6 to 8 centimeters with an FiO2, the European guidelines today have brought down this FiO2 to around 30%. So at about an hour and a half after delivery, with appropriate good CPAP with a proper interface, which is short binasal bronchs or a mask, either a bubble CPAP or a ventilator. If there is a requirement of more than 30%, some units still continue to use a 40%, but this is an individual unit decision. We may use early rescue surfactant, or any baby that needs mechanical ventilation, we may require early rescue surfactant. Then there are criteria of how to give the second dose, but this algorithm needs to be remembered in our mind. This technique is called the LISA or the MIST. And the benefits of this technique, the first and foremost, we need to ensure that there is continuing CPAP during the procedure. We generally would not sedate. We would not give any sedative because we want the baby spontaneously breathing and ensure good, effective CPAP delivery. The benefit, the biggest benefit, it avoids an unregulated delivery of tidal volume. So there is no PPV that we deliver as we would do with the INSURE technique. And it has been shown through large studies, through systematic reviews, to decrease the need for mechanical ventilation, the combined outcomes of death of BPD or even IVH. And today it is standard of care across any units. There is a learning curve, but we all must increasingly start learning this procedure to benefit the smallest babies. These are some of the surfactant preparations that we commonly use. These are the natural surfactants. And there is something on the horizon in the form of an artificial surfactant also. This ABG showed severe metabolic acidosis with a base excess of minus 28.9 with the respiratory compensation. What are the conditions? The anion gap. So the anion gap is a combination of sodium plus potassium minus the unmeasured anions, which is chloride plus bicarb. In this case, comes out to around 26.9. The conditions which cause such severe metabolic acidosis in neonates ranges from sepsis, shock, to even severe perinatal asphyxia. Now, the predominant organisms that cause neonatal sepsis, I think we missed these two questions in the question. I'm sorry about that. As per the Lancet study 2016 in the LMICs, the gram-negative bacilli continue to remain the most common organisms, causing both early onset and late onset. Unlike the West, we in India and other LMICs, we don't seem to see this differentiation between the organisms causing either early onset or late onset. And we seem to have gram-negative bacteria, typically Acinetobacter, Klebsiella, E. coli, as the big organisms. Surprisingly, in the study of 2016 with an outborn unit, this was the Chacha Nehru Bal Chikitsalaya, Candida sepsis was almost 24% among the outborn babies. So we need to keep this in mind. Our typical understanding of fungal sepsis is ELBW, prolonged ventilation, prolonged TPN, long stay, multiple IV lines and procedures on broad spectrum antibiotics. But even on the first day, second day, third day, in outborn babies, Candida sepsis was a leading cause. So we need to keep this in mind. And the last question, we all know there is recommendation of either a single course of dexamethasone as per the government of India or betamethasone, whichever is available, for a total dose of 24 milligrams in all women who present with threatened preterm labor between 24 to 34 weeks. The maximal benefit is after 24 hours. And there is a case for one additional course in those women who remain undelivered even after about a week or two of the first course, and the gestation is below 32 weeks. And there is no evidence for repeated or multiple courses. It is considered harmful. The benefits, it reduces neonatal mortality about 30-31%, RDS something similar, need for mechanical ventilation, IVH and NEC, and huge number of other benefits also. Thank you, Kavita ma'am. I'm done.
Thank you, Dr. Sridhar. It was I think I can call it exam-oriented OSCE because these are so useful for the students to answer exam. I'm sure they're very grateful to you. Thank you so much for being an examiner, and I think we had a good session today. So thank you to all the students who presented and attended. And I think we can end this session.
Thank you.
Dr.
Thank you so much, ma'am. Yeah.
Thank you, everyone.
I'll share the FEAT scoring sheet with you, ma'am. Thank you.
Sure. Thank
Yes.
you.
Okay, Sarita. We'll see you next
Okay,
Wednesday.
good. Yeah, good night, ma'am.